Welcome back to the Blood Clot Briefing. While prevention is always our focus, sometimes blood clots happen, even when you do everything right. So what comes next? In this episode, we're diving into the treatment options for venous blood clots, from medications like Apixaban and Heparin, to rare cases where surgery might be needed. Whether you've had a clot yourself or you're supporting someone who has, this is one you won't want to miss.
Hi everybody, Thrombowatch here again. I'm with Dr. Aman Sharma. I'm Louise Thompson. We talk a lot on Thrombowatch about prevention. That's our main focus. But there are times that no matter how hard you work at making sure that you don't get a blood clot, you still do. Sometimes it is just unavoidable and there's nothing that you can do to stop it. So that leads to some further questions that I'm going to ask Dr. Sharma today, because what happens when you've got a blood clot? What are the possible options for treatment? What's the pros and cons of them? And how far can the treatment go?
Great question. So we would only be talking about the venous thromboembolism. I'm not going to talk about the clots in the arteries. Okay. So the veins and the arteries are two different types of blood vessels in the body. Arteries take the blood away from the heart into the tissues, whereas veins bring the blood, the deoxygenated, the less oxygen blood from the tissues back to the heart. Okay. So we'll be talking about the blood clots in the venous system only, just to make it easier and simplified. So let's talk firstly about the deep vein thrombosis. So when we talk about the deep vein thrombosis, you can have them in the legs, which is the predominant common site, but we can also have them in the arms. Did you know that we can have DVT in the upper arms?
I've heard, but
Yeah,
I've not heard it often.
It's not that common as the legs, but definitely. So if we talk about DVT first, so people who've got DVT usually should not have compromise of their blood pressure, heart rate, and breathing difficulties and stuff, because it's very much localized into the venous system of the legs or the hands. So in such cases, they would be needing treatment to make sure that the blood remains thin and we can stop the further progression of the clot. So in terms of the classification of the blood thinning medications, the number one agents that we used in the past were the vitamin K, as we said, the rat killers, the comedins. So warfarin was the most common drug which was used. However, with the advancements now, warfarin is very much restricted to people who are quite overweight and those who've got kidney problems, because warfarin is relatively safer in people with kidney problems. But in the newer time, we use something as the factor 10 inhibitors or agonists, which basically constitute of the medications that you hear commonly these days, which is the Apixaban, Rivaroxaban, Edoxaban. So these are all these medications. So they also act in a different way. They inhibit one of the enzymes, thus help us preventing further clot formations. Then we have the direct acting anticoagulants. The most common example is dabigatran, which is rarely exclusively used in few cases than rather than the common population. And then we have the heparins. So we can have either unfractionated heparin, which is not commonly used with DVT, but the other enoxaparin, and as you were saying, a drug which was used in your father's time. What was the name of the medication?
Tinzaparin.
So it's been discontinued now, but yeah, those were all the group of these medications. So those are the fairly common medications that you would use if someone has got a DVT. Again, the duration of the
Just ask a quick question. Are the heparins injected?
Very good question. So heparins, usually the low molecular weight heparins would be injected subcutaneously, as in where you have got some fat in your body. It can be your thighs, it can be your belly. These are the predominant sites. But yes, if you're talking about unfractionated heparin, which I would talk the indications further, then you would have to give them intravenously. They goes through the veins directly into the bloodstream. So they're not commonly used. There are only few conditions where we use them. So for DVT, these are the main treatment. Of course, when we talk about pulmonary embolism, and especially in cases where you've got saddle embolus, okay, I will show it to you guys what a saddle embolus means shortly. So basically, I'll tell you how the system works with the lung. So this is your windpipe that comes and gives away. So this would be essentially your lung on both ends. However, the shape is a bit different on the left side because the heart needs to come in. So basically, your heart would come and sit up here. Yeah, it's roughly this in shape. And then you get the blood vessels coming from the lungs into your heart, which we call as the pulmonary blood vessels. So this would be coming and this would be coming. It's not exactly how it comes, just to make you better understanding of it. And of course, they would be going into the lung and trying to get the blood from the lung so that the blood can be brought into the heart. So, what happens when we say about the blood embolus or the pulmonary embolism? So, the blood clot can form somewhere here, right? So, this is on the outside. So, we would call it as a peripheral blood clot. These blood clots can be treated with medical management and they will not cause a big compromise in the patient's condition because they would eventually affect a small part of the lung. Whereas the same person now gets a saddle embolus. I'll draw with red color here. So, saddle means a big sort of blood clot at the entry port of the blood vessel. So, now you've got a big blood clot. So, this lung gets quite disrupted because of this, and since there's no blood vessel, no blood coming or going out, this puts a strain on your heart as well, which we call as right heart strain. So now your heart is getting devoid of blood, your heart is not able to pump enough blood outside the body, thereby reducing your blood pressure, thereby reducing your oxygen levels, also playing up with your heart rate because it's going up so that it can produce more and more circulation because the other lung's still working. So in this type of conditions where you got a massive clot sitting on the tip of the blood vessel where it originates, we call it as a saddle pulmonary embolus, and this condition usually needs the higher medication, the thrombolysis medications. Otherwise, these people may die. So, if person who are hemodynamically unstable because of the large clot and causing pulmonary embolism, again, for them we need to give them a medication which will basically disappear the clot. It's called thrombolysis, as the word means thrombus, lysis, thrombolysis. So then we give them a very specific medications like alteplase, which would usually lyse the clot and help save their lives. Okay, but if someone has got clots which are fairly located in the peripheral parts of the lungs, they do not need these blood lysing medications because they also come up with fairly sort of side effects in terms of they can cause massive bleeding and stuff. So again, the treatment would be these same groups. Okay, warfarin restricted only to few specific people who are overweight and got kidney problems. Otherwise, we would use Apixaban, Rivaroxaban, Edoxaban. People like in special groups now, like pregnant women, cannot have these medications, so they would be treated with Enoxaparin, that belly injection that we were talking about. And again, dabigatrans and stuff are usually not commonly used with pulmonary embolism. Have you ever heard someone going for a surgery for a pulmonary embolism?
No.
No. So it's called embolectomy essentially because you're taking the embolus out. So it's not fairly common. It's
So-
not routinely used.
Sorry to interrupt. You say thrombectomy. Say it again for me, please.
Pulmonary embolectomy.
Embolectomy.
Yeah.
I'm thinking of appendicectomy. So what does ectomy mean?
Take it off.
Take it off.
Yeah.
So you're talking about taking off the clot.
Yeah. So it's not fairly commonly practiced. It's very rarely performed in people who've got massive clots which are not responding to the usually medical management, or people who've got chronic clots and they're just getting piled up on those clots. For those people only we would consider, or it's a very advanced sort of surgery. And when you talk about the risk versus benefit, you have to weigh the risks, and it's quite risky, to be honest.
So what happens if you're going for one of those then?
Very good question. I think it's not like it's never done. As I said, for specific indications, it might be done. But yeah, essentially, you take the clot off as much as you can, and the cardiothoracic surgeons are the one who do it. The main goal of doing it to save life. So it's more of a life-saving surgery than an elective surgery. So if if there's indications and your surgeons think that's the only thing that's going to save you, and the physicians and surgeons have done a sort of multidisciplinary plan for the patient, so that times it can be done. But in a routine world, if the patient is hemodynamically unstable, we would give them the lysing medication, the thrombolysis, and usually if they're hemodynamically stable, we would just give them the enoxaparin, or for the longer run, or because taking the belly injection is not comfortable to everyone, whereas taking a pill is relatively good. And as we've talked earlier, if you get on these newer factor 10A medications, so the effect is good, and you don't have to get your bloods tested every now and then. You don't have to marginalize the dose. The dose are pretty much fixed, and they work brilliantly on that aspect.
I'm still at the I can't even say it.
Yeah.
Say it for me again. Pulmonary
embolectomy.
Thank you. I'm still there because I got questions. Is that open heart surgery? Is that keyhole surgery?
Yeah. No, it's usually not done open. So we do go from the vascular technique. So essentially the big vessels in your groin, the femoral vessels, we go through it and then we reach the heart. And from there you go to the lungs either side and try to take it off.
Okay, watching it on the TV.
Yes, essentially that's how it can be performed, because you won't be opening your chest wall to take the clot off. Again, as
I'm
I
pretty
said,
pleased about that.
the risk versus benefit, the risk is way too high and you might develop the clot again. It's not like someone getting a bypass surgery. If you get it done, you get a couple of years of life. It's not like that. It's a soft clot which can essentially form again, and potentially it's not worth opening, and it's not, I don't think it's done in a routine practice at all.
Okay, thank you.
But there's one more thing, since we're talking about the venous clots. You would have heard people getting a clot in their venous system in the head, which we call as cavernous sinus thrombosis. If person have those, these people would usually need a continuous heparin infusion. So that's the only indication. If someone has got a clot in the venous drainage system in their head, they would need it. Again, we don't need to operate their skull out and don't need to retract the clot, but essentially the blood thinning medication, the heparin, is what is indicated. But yeah, we can always work on preventing things. Yeah, but someone's got it, they would be usually on the medication dose for 3 months, 6 months, lifetime, depending on what precipitated it and how did they get it, and whether the risk is for them to have it again. So that's again weighing in the benefits versus risks. That's how we plan whether they need longer term, shorter term, or no anticoagulation at all.
Thank you. You mentioned in the brain, which is kind of new to me again. So how would somebody present with something like that?
Very good question. So headache is the main symptom essentially. What we also find that is people, if they bend down,
Okay,
and the headache gets worse with it, okay, that can also be a potential. It's not once it happened and once you bend down your head's going to hurt or something. It's a very sort of constant pain. It doesn't go away taking painkillers. People might feel a bit drowsy and as if they've been knocked out or something. So in those cases they would need a CT scan. It's usually the plain CT scan doesn't catch it, so they need something called a CT venogram. So they're given some contrast through the veins, and the CT machine catches the images of the brain, and then they can see the blood vasculature in the brain. If there is a disruption in the blood flow, then we say, oh, they've got CVST or central venous sinus thrombosis.
okay, thank you. I was going to talk a little bit about my dad. I've talked in the past, my dad had factor V Leiden. My dad had the first clots in our family, and he never needed any surgery. He had a lot of drugs for it. So he had the heparins, particularly if he was going to have surgery. So he had knee replacements and hip replacements. And if he did that, he had to come off his normal medication, but then he would get injections after, usually in the 5 days after surgery. If he'd had knee replacement surgery, for the 5 days after, he'd have injections, and then he'd go back onto his normal medication. And for a few days before the operation, he'd stop medication altogether, and that was always quite a scary time. But after he'd had it, he was on these injections. But then he would also have, I can picture the bottom of his bed, and he had this machine that was pumping to make the circulation boosted.
So yeah, basically they are called in common language we call them as the floatron devices. So what it essentially does is, if your legs muscles or your leg soft tissues are constantly getting squeezed, so you're still getting a good blood flow despite they not having a good physical movement. So that basically comes and squeezes the area on and off, on and off. So it's basically trying to mimic the movement if someone would have done it. So people usually who got stroke are being given the floatron devices, because again, because of the stroke, if they've got limb weakness, they can't move the limbs, isn't it? So even if we give them the blood thinning medication, that might be effective, but the stockings won't be that effective. That's why, especially for stroke people, we do try to put them on the floatron devices. Also, people who are in critical care have been severely ill, they can also be given the floatron devices rather than just giving the blood thinning medications.
Is it worth asking if you're in hospital and you've got a history of DVT, you're having surgery, is it worth asking if you can have that floatron, or would it
Good
always...
question. Not in a routine, because see, even if you're getting a surgery, you should be able to move your leg, isn't it? So I think the obvious indication and the people which we most commonly use the floatron devices or this mechanical pumps are people with stroke, because unfortunately, if they've suffered a massive stroke, they can't move their hands and
Okay.
limbs, and that would further lead to stroke clot formation in the limbs.
Okay, so it's more unusual. Okay, so just to sum all of that up then, you've got, do you want to just quickly cover it?
I
list
would
them
say
off
we've
again?
got a list of pharmaceutical agents which can be taken orally, which can be taken subcutaneously, which can be given intravenously. Okay, depending on the overall condition of the patient, whichever suits them is taken into consideration. Also, if they've got renal impairment or they're heavily obese, then we have to think more about warfarin. If they are still under 150 kilograms, we can use enoxaparin as the tummy injection. And again, special circumstances where people are specifically allergic to one medication or the other, then we have to do a bit of a brainstorming and come up with a plan where we still prevent the clot formation and treat their condition and also don't cause potential side effects to them. So it basically would vary from person to person, but in general, again, medications for a specific period of time, and usually they should be feeling better with it.
And then surgery, very unusual.
See, we can talk about the arterial thrombosis in another episode. And for the arterial thrombosis, yes, surgery is the mainstay of the treatment,
Okay.
or invasive intervention is the mainstay of treatment. But usually, if we are talking about venous thromboembolism, we can usually treat it with the oral pills, getting more invasive, or giving them very specific injections which would cause the blood thrombus to completely dissolve.
Okay, thank you.
This podcast is for informational purposes only and does not constitute medical, legal, or financial advice. The views expressed are the personal opinions of the Thrombowatch team. If you think you may have developed a blood clot, please speak to your healthcare provider urgently. Health-related information shared in this podcast, including text, graphics, images, and other material, is intended for educational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your doctor or another qualified healthcare provider with any questions you may have regarding a medical condition. If you believe you're experiencing a medical emergency, call 999 in the UK. For less urgent support, call 111. Thank you.